Hi, Mike Gibson, Steve Nissen, joining you live from ACC 2024. Steve, talk to us about your study where you looked at technology assistance in prescribing non-prescription rosuvastatin.
First of all, let's talk for a moment about the background. We know that less than half of the people in primary prevention who would qualify by guidelines for statins are actually getting treated. We have a huge gap, and the question is how to close that gap. 5 prior efforts to develop over-the-counter statins have failed because the wrong people were taking the medications. They used something called the drug facts label, which is what appears in an OTC product, to guide people in self-selection for statins. And it didn't work. The worried well took them, or people that might have, contraindications took them. So it didn't work. So working with AstraZeneca, a group of academics, have developed with them an alternative approach. It's one where there's a web app. You go on the web app, you enter your data. You have to have your cholesterol levels and your demographics and so on. And it then, behind the scenes, uses the risk calculator to calculate your 10-year risk. If you fall in the range that qualifies for statins, you get shipped directly to your home non-prescription rosuvastatin. But in order for this to be approved, we needed to demonstrate whether that strategy would work or not. So the TACTiC trial was a 1,200 patient trial where we had clinicians assess eligibility for statins. We had the patient assess eligibility using the web app, and we compared concordance. They were then treated for 6 months. They actually got the drug. They actually had to pay for it. It was shipped to their home. And at the end of the study, they were retested to see whether they actually got the intended reduction in LDL cholesterol. Now, the first primary endpoint, there were 3 co-primary endpoints. The first co-primary endpoint was the concordance between clinician assessment of eligibility and patients using the web app. What was their assessment of eligibility? And concordance was about 91%. This is much higher than has ever been achieved in a non-prescription statin trial. The second primary endpoint was a final use assessment. Were they in fact still concordant with clinicians after this 6-month treatment period? And about 98% concordance by the end of the study. Did they use the drug properly? Did no new contraindications develop that they did not assess? And the final co-primary endpoint was how much LDL reduction did they get? And they got 35% LDL reduction. From a baseline of about 139, they were reduced by 35%. What did we learn? We learned that using technology, using a dedicated web app, essentially as medical software, that we could develop a non-prescription access to rosuvastatin 5 milligrams, just the 5 milligram dose was available, and that people could self-select correctly, that they could use the drug correctly, and that they could get a highly clinically meaningful reduction in LDL cholesterol. This study will go now forward toward an FDA evaluation, and we think that it very well will lead to the first availability in America to a statin without a prescription via web app self-selection.
Amazing, Steve. Congratulations. I think you're seeing more and more these direct to patient approaches.
Yes.
With the weight loss drugs, with Eli Lilly and others now offering telehealth services, you're seeing this more and more. So, do you think this pattern is going to extend to other drugs, or is it just going to be preventive therapies?
Well, it's actually a very interesting because this will be the first time a non-prescription drug has been available for a condition without symptoms. High cholesterol, as you know, doesn't everybody knows, doesn't have any symptoms associated with it. Um, all the other non-prescription drugs out there, for proton pump inhibitors or analgesics, are all to relieve symptoms. So it's a unique approach. We had a very good executive committee that was involved in helping AstraZeneca with this trial. A lot of people who are experts in lipid and other, aspects of self-care. And we think we got this right. Um, I'm very optimistic that this will allow people access, people who don't have good access to clinicians.
Right,
What if you live in rural Montana or
right.
some places in the inner city where there's not very good access to physicians? Now, there are some limitations. First of all, the app is in English. So this would only be applicable to people that can read and understand English. And you do have to have internet access to use the program. Fortunately, in contemporary society, internet access is almost universal. So we aren't leaving out very many people, but we are leaving out some people. There certainly are, limitations to this approach. Uh, the full manuscript associated with this study will appear simultaneous with presentation in JAC, and everyone can kind of read it and look at the details. Let me also add that the concordance was adjudicated by a central adjudication committee at our Cleveland Clinic C5 research team. So, this was an academic industry collaboration. And as you and I both agree, that's the optimal way to run any clinical trial or clinical study, to have this kind of collaborative approach.
Congratulations again, Steve. I look forward to seeing what you can do also with dose escalation as needed to achieve different targets.
Yeah.
That would be exciting to see as well.
Yeah, yeah, that's not quite on the drawing boards yet, in part because we knew that 5 milligrams of rosuvastatin was very well tolerated. The adverse effects, this is 1/8 of the top dose, are very low. This was not an effort at titration, and we may never go there. Whether the regulatory agencies would be comfortable with high intensity statins available without a prescription. And remember, we're only treating primary prevention patients. These are not secondary prevention patients. In fact, if you in the web app declared that you'd had a heart attack, a stroke, or any other kind of cardiovascular event, you were excluded. You were directed to see your doctor for high intensity statins. So part of the advantage of this is we can educate consumers. We have transactional emails, so we can remind people to reorder. There are a lot of things about this that we think will improve adherence to statins, which will be a public health advantage of this type of a program.
Again, amazing. I think this is really, really, really important, Steve. Thanks for sharing with us, and thanks to all of you for joining us here live from ACC 2024.